post-sepsis syndrome. We are all treating sepsis and in ICU, but majority of the cases having some complications after recovery. Even at going home also, they are having some psychological issues and some complications. Now Dr. Srikanth is going to talk on the post-sepsis syndrome. Srikanth, please start the presentation.
Thank you, sir. Thank you so much. It's whenever we talk very much more about sepsis management and antibiotic coverage and all, but once we have successfully brought out a severe sepsis patient or a septic shock patients and we transfer them to wards, we may be a bit more busy with the current existing cases in the ICU. Even though we follow up sometimes in the floors how they are doing and all, our entire focus will not be there to those patients. And also when they're again discharged from the floors to home, again the duty doctors most of the times write the instructions and all, and the follow-up also, even though if we directly say to patient attendants and train our staff also, when they come for first follow-up, sometimes they may not see us who have primarily treated the patient and brought him back to routine lifestyle. And as Mohan sir mentioned, is it similar to PACS? So yeah, it's like more of not a similar picture, but sepsis patients carry even more of those debilitating features what we can see in post-intensive care syndrome, because the alteration of routine organ function will be much more affected severely in the sepsis patients. So we'll briefly look into what are all the things that can happen, how they present, and most of the therapies or treatments which are in experimental stages, and current strategies, how we can improve the quality of life in the post-sepsis patients. So then we can actually discuss what are all we are doing and how in many areas, in how many areas we can improve in our current practice. So coming to the introduction, there is my voice is very bad. Sorry, having cold and sore throat since 3-4 days. So there is scarce data that describes the long-term consequences of sepsis and how to optimize health post-sepsis. The mortality rates after surviving the initial sepsis episode remain high, and unfortunately, most of the times we are not even aware of this. So depending on sepsis severity, the 1 year post-discharge mortality rate varies between 7 to 43%, which is almost like 1 in 2 patients you're losing when you see at an upper end. And 5-year mortality rate after severe sepsis is 82%. So half of the deaths after sepsis are caused by recurrent infection and cardiovascular events. So long-term mortality is often due to the so-called post-sepsis syndrome, which can be defined as a consistent physical, medical, cognitive, and psychological issues after sepsis. So that's a brief pie diagram showing how many patients will recover mortality and post-sepsis syndrome presentation. So it will again increase the readmission risk for infections and the incidence of cognitive impairment, mental health problems, renal failure, and cardiovascular events compared to non-sepsis hospitalized patients. So this is a brief diagram showing various symptoms and signs of post-sepsis syndrome. So it constitutes both physical and psychosocial long-term efforts that can impact up to 50% of sepsis survivors. So there can be muscle weakness, fatigue, difficulty in swallowing, cloudy thinking, difficulty in concentrating, poor memory, sleeping difficulties, persistent dull mood and all. So you can have physical signs like hair loss, shortness of breath, reduced organ functions, some skin rashes, and disabling muscle or joint pain, which is seen in most of the patients post-sepsis. So in this brief talk, we'll be addressing all these topics which are caused due to post-sepsis syndrome. And in each subheading, we will be discussing about the topic and also the treatment, the therapeutic opportunities for each individually, and sum it up at the end. So coming to rehospitalization risk, almost a third of all sepsis survivors are readmitted to the hospital within 90 days, while patients who are more than 50 years of age are among that population, nearly half are readmitted within 90 days. Most of the times you may also have noticed like recurrent urosepsis, the elderly patients getting readmitted sooner than expected. Sometimes maybe within like 1 or 2 weeks, they are again getting readmitted and all. So the fever cases, all, and we have seen the pandemic, COVID, post-COVID-19, the readmissions are very high because of the cardiovascular and other infections. Just a few months back, nephrologists were also mentioning that the cases of pyelonephritis increased after COVID-19, especially compared to before pandemic. So these are recurrent admissions. We generally, if the period is immediate within 1 or 2 weeks, we consider it as the same common syndrome like that. But when it's past like 2 months or 3 months, we treat that as separately. But actually, there is an ongoing immunosuppression or the changes in the body due to sepsis, which are causing the rehospitalization risk. So up to a third of these readmissions are due to recurrent sepsis, while the other common causes are heart failure, pneumonia, and ARF. So sepsis survivors have a twofold higher incidence of sepsis and nearly threefold higher incidence of ARF compared to age and comorbidity matched subjects surviving hospitalizations for other acute medical diagnosis. So recurrent sepsis remains a problem. It's not just a few months or couple of weeks problem. Sometimes for years, they can have a risk of recurrent sepsis. So that can be stretched as long as an 8-year period. So most sepsis survivors develop recurrent sepsis compared to randomly sampled patients from a health registry. 35% of recurrence compared to 4% of other causes patients. So while recurrent sepsis caused nearly 1/3 of deaths in sepsis survivors during this period. So among the deaths that occurred in post-sepsis cases, recurrent sepsis was the cause of 1/3 of those deaths. So thus rehospitalization and mortality due to sepsis recurrence and non-septic causes constitute a lethal problem for sepsis survivors. So what can we do? Can we prevent the rehospitalization risk and all by doing some changes when they are actually in the hospital suffering from sepsis or septic shock? So sepsis induces a state of persistent low-grade inflammation, prolonged immune dysregulation, and mitochondrial dysfunction, which results in increase in infection risk and cellular damage. So thereby making, due to these changes in the body at the cellular level, these will make survivors more vulnerable to recurrent sepsis episodes. And also the same risk factors which have led the patient into sepsis and the admission will be present post hospitalization also. So the risk of readmission will be the same, and it's how difficult it is to prevent these episodes. So possible strategies can be active surveillance of reinfections, so that needs training at primary healthcare level too, and prophylactic antibiotics, vaccination, and when possible, minimizing the use of invasive devices. So involving urinary catheter pacemaker. But again, this is a challenging thing. Minimizing the use also. Most of the times we need them for the effective treatment of the severe sepsis and avoiding drugs that suppress the immune system. So these are the possible strategies. Again, you have to balance the usage and overusage part to prevent not only the current complications, and also you have to think about after the recovery, how much these are going to affect the patient. You have to keep in mind. So, however, as we discussed, these strategies may not be feasible in all situations and are associated with side effects, including the risk of antibiotic resistance to give prophylactic antibiotics post discharge. And while avoiding invasive devices or immunosuppressive drugs may not be possible for those in need of this therapy. So one common thing, we in the discharge summary, we write for 5 days or 7 days of antibiotics and all. Sometimes people don't know, or the local practitioners who are there can misguide them. Sometimes they end up, we have seen quite a good cases where they have used we have written 1 month follow-up. So till 1 month, they're actually using the antibiotics too. So we have clearly written there 1 week. We told them at the discharge, and then also say మీరు చెప్పలేదు or మీరు క్లియర్ గా చెప్పలేదు. So they will end up using 1 month of antibiotics in such cases and all. So thus to enhance health and lifespan after sepsis, it is necessary to identify feasible strategies to lower the risk factors that predispose patients to recurrent sepsis episodes. So coming to prolonged immunosuppression, as the recent studies pointed out, so apart from the hyper-inflammatory phase, there is also overlapping immunosuppression evident even in early sepsis and persists after patient discharge. So the recent focus has been expanded to the occurrence of an immunosuppressive phase occurring concurrently with the hyperinflammatory phase, which is marked by lymphocyte apoptosis and cellular reprogramming of innate immune cells. So there will be a cellular reprogramming of the innate immune cells where our immune cells are not able to mount an adequate immune response to infections post-sepsis. So 1 in 5 ICU sepsis survivors had positive blood cultures up to 150 days after sepsis, among which there were more opportunistic bacterial and candida infections than during admissions, so suggesting a prolonged inability to clear infections from the patient side. So the sepsis survivors have reduced pro-inflammatory interleukins and TNF-alpha secretion, as well as a substantial decrease in the anti-inflammatory IL-10 secretion at 9 to 52 months. That will extrapolate to 52 months since 1 year after discharge when compared to healthy controls. This is indicating a sustained inability of the immune cells to mount an effective immune response post-sepsis. So the coming to mechanisms underlying the sepsis-induced immune dysregulation.
9 to 52 months ante
1 year, sir. Yeah.
52 months ante.
Sorry, sir. 52 months ante it's like 52 weeks and then 52 months, that will come to around 4.5 years, like that. 4.5 years. Sorry, sir. So coming to mechanisms underlying sepsis-induced immune dysregulation. So these are epigenetic changes, long-term effects on immune cell numbers, immunological endotypes associated with poor outcomes, and therapeutic opportunities. So coming to epigenetic changes, altered DNA methylation and histone modifications are observed in human patients and murine models post-sepsis. So these changes in DNA methylation and histone modification will result in repressed expression of the immune-related genes encoding TNF-alpha, interleukins, and chemokine ligand in macrophages and dendritic cells, and also interferon gamma in CD4 T cells. So murine bone marrow progenitors have repressive epigenetic modifications affecting inflammatory gene promoters 4 weeks after sepsis, producing macrophages resembling the impaired macrophages found in sepsis survivors. So in a nutshell, these changes at the genetic level will cause the decreased inflammatory markers, and these will actually result in prolonged immunosuppression or immune dysregulation post-sepsis. So this will provide a potential cause as to why new innate immune cells formed after the initial septic episodes appear to remain reprogrammed. So coming to long-term effects on immune cell numbers, so sepsis carries long-term effects on adaptive immunity. The acute sepsis leads to decreased number of CD4 as well as CD8 plus T cells due to apoptosis, followed by reversal to levels found in healthy individuals at 6 months after discharge. So even though, despite the numerical recovery of their numbers at 6 months post-discharge, they have impaired immune response. Even though the quantity is restored within 6 months, the quality remains impaired after that period also. So these long-term functional deficits may be due to presence of immature neutrophils and granulocytes, which are called as myeloid-derived suppressor cells. So these MDSCs increase in number, which have actually T cell suppressing capability. So number of circulating MDSCs are elevated during sepsis and remain elevated up to at least 4 weeks after discharge. So furthermore, sepsis is associated with increase in number of reg T cells, which will persist for at least 5 to 10 months afterwards. So as the regulatory T cells, we all know, play an important role in dampening the immune response. Their increase in numbers may well contribute to persistent immunosuppression. So this is a diagram showing the concurrent pro-inflammatory and anti-inflammatory efforts. So if you look at the immunosuppression, all these changes will happen. The increased MDSC proportions will lead to prolonged immunosuppression, which can actually lead to recurrent sepsis, rehospitalization, and a late death after sepsis. Okay. Now, immunological endotypes associated with poor long-term outcome. I think we had this talk in Criticare Indoor also about the endotype stratification in sepsis. So the recent studies have described the ability to stratify the patients with sepsis into 2 to 4 phenotypes, different phenotypes, using retrospective clinical data or whole blood transcriptome data. And also the septic ICU patients are classified in 4 endotypes based on the same whole blood transcriptome analysis. So these actually identified an endotype with decreased expression of key regulators and components of innate and adaptive immune system. That was associated, that particular endotype is associated with the highest mortality rates, both at 28 days and 1 year after discharge. Sorry. So these gene encoding proteins involved in innate and adaptive immunity that are reduced in expression during sepsis, they remain in the same way at lower levels in sepsis survivors also when compared to healthy controls. So conversely, this is one endotype, they have observed a lowest mortality. This has actually increased expression of key genes involved in the adaptive immune regulation. This is supporting the concept that functional restoration of T cells actually might reverse post-sepsis immunosuppression. So these are all actually in the experimental stages, and we can see in near future how we can alter the treatment modalities, and with the newer treatment modalities, we can actually decrease the incidence of post-sepsis syndrome and also the recurrent hospitalization and deaths due to that. So coming to therapeutic opportunities, so epigenetic markers can be modified in vitro to reprogram the immune cells. Although such therapies have not been clinically tested at this point, like histone deacetylase inhibitors, so therapies such as IL-7 or checkpoint inhibitors are currently in human trials and show potential to reverse long-term T cell dysfunction in sepsis patients. However, until such strategies are available in the market for us to use, active surveillance of sepsis survivors and infectious disease control measures are the best bets to prevent recurrent episodes of sepsis. So coming to cognitive dysfunction post-sepsis, long-term cognitive issues, which is deficits in processing speed, attention span, perception, and memory are a debilitating consequence of sepsis. These deficits affect up to 1 in 5 sepsis survivors and can last up to 3 years post-sepsis episode. So persistent cognitive defects leads to a poorer quality of life and an increased risk of rehospitalization. So sepsis survivors have a reduced hippocampal volume and evidence of blood-brain barrier breakdown as detected using MRI. So this is a diagram representing the mechanism of neurocognitive decline after sepsis. So the peripheral organs and secretions, which will lead to increased immune cells, are damaged macrophages. So these will secrete the increased number of high mobility group box1 protein, which is HMGB1. So this will ensure that there is a persistent inflammatory state post sepsis. So it will cause a blood-brain barrier compromise, decreased CVF, and the leakage of the neurotoxic factors like cytokines and glutamate through the blood-brain barrier. And also there is increased acetylcholinesterase activity. All this will lead to a triad of cerebral ischemia, neuroinflammation, and impaired neurotransmission, which will club together to cause a significant neurocognitive decline in the post-sepsis patient. Okay, so coming to therapeutic opportunities for the neurocognitive symptoms. So inducing mitochondrial biogenesis to increase mitochondrial mass improves the cerebral ATP levels and cognition. Consequently, therapies are aimed at preserving the cerebral mitochondrial homeostasis may prevent cognitive impairment post-sepsis. So coming to neuropsychiatric consequences, severe sepsis can have a long-lasting effect on mental health. So PTSD is a common diagnosis in critical illness survivors, and sorry. At this point, it actually overlaps with the PSES, post-intensive care syndrome too. They also have a post-traumatic stress disorder. So nearly half of critical illness survivors suffer from PTSD at 6 months after discharge. So which is associated with increased rates of, again, substance abuse and sleep disturbances. So depression and anxiety are seen up to a third of survivors of critical illness 3 months after discharge. So coming to therapeutic opportunities, this is a point I learned when I was reading, to keep an ICU diary. One intervention to manage PTSD after sepsis is keeping an ICU diary written by either health workers or family during the ICU stay of the patient. And a 1-year intervention involving primary care physicians and nurses trained in post-sepsis care also prevented an increase in PTSD symptoms in sepsis survivors 2 years after discharge. So the REPAIR clinical trial, which is currently in progress, will reveal whether cognitive behavioral therapy is an effective way of reducing PTSD symptoms after sepsis. So coming to cardiovascular and kidney disease, sepsis survivors have increased risk of fatal cardiovascular and kidney disease, including stroke, MI, heart failure, ventricular arrhythmia, and CKD. So basically, this will cause an alteration in mitochondrial architecture, as we are discussing various systems and all. The basic pathology occurs at the mitochondrial level. So the damage to mitochondrial DNA and a decrease in mitochondrial mass. So besides the mitochondrial damage, it also associated with dysfunction of mitochondria. So that is lowered mitochondrial membrane potential, ATP production, and increased mitochondrial reactive oxygen species. So coming to therapeutic opportunities, potential interventions can include inhibition of mitochondrial ROS reactive oxygen species production to prevent mitochondrial and cell damage, and inducing mitochondrial biogenesis to restore mitochondrial mass and oxidative metabolism. Some extent, definitely our antioxidant therapy, prolonged antioxidant therapy, all this will definitely help till the time this novel drugs or mechanisms to reduce the mitochondrial damage comes into market. So further implicating a key role of mitochondria during sepsis is the impaired cardiac mitochondrial function, which reduces calcium uptake, leading to sarcomere destruction, contractile dysfunction, which will cause the heart failure in post-sepsis patient, and heart failure. So statins and modulation of HDL levels might reduce the risk of cardiovascular events. Again, there are studies supporting this hypothesis and also contracting. So at this point, there is no strong evidence to say that actually the statins and modulation of HDL levels will help in reducing the risk of events. So overall functioning and quality of life, as we all can expect, sepsis survivors continues to have a reduced health-related quality of life for at least 5 years of discharge, which is actually a frightening number, 5 years after discharge. So particularly in the physical domain, when compared to age-matched controls. Similarly, almost half of acute COVID-19 survivors reported decreased quality of life 60 days after the onset of symptoms, compared to before developing COVID, mainly due to fatigue and joint pain. This one we all have heard during the pandemic. So decreased physical function may be due to loss of muscle mass during sepsis, though it is completely understood why muscle regeneration is impaired after the sepsis. So coming to therapeutic opportunities, mesenchymal stem cell therapy is under investigation and is not yet approved for improving the muscle mass and developing the quality of life. Meanwhile, physiotherapy can actually improve physical quality of life after sepsis. Initiation of physical rehabilitation within 3 months after discharge not only improved physical strength, but also reduced 10-year mortality in sepsis survivors as compared to sepsis survivors who did not receive physiotherapy. So furthermore, early mobility interventions improve physical function at discharge as compared to patients who received only primary care during sepsis. So regarding this early mobility interventions, we had a very nice pro-con session in our Reflect recently. So the benefits of physiotherapy are likely mediated by improved mitochondrial function and reduced inflammation, which then improves both physical and cognitive health. So current and future therapeutic opportunities, if we can put it in a single slide, sepsis follow-up clinics, which are very important. We can try to implement that. So where we can ask patients directly to come and meet us. We can set up a chamber in our hospital. Training is of paramount importance. So which is another area we are lacking. As you can see, this is released by CDC. When compared to early signs and symptoms for elderly patients, appropriate diagnostic tests. So the training actually helps a big time in identifying post-sepsis syndrome and getting them treated properly. So after training, they say the chances of identifying and treating the post-sepsis syndrome are increased from a mere 5% to 100%. So at least we can achieve a 60 to 70% target initially with proper training of our staff and all. So phenotype and endotype stratification, physiotherapy and early mobilization, preventing mitochondrial damage or restoring mitochondrial function, minimizing the invasive interventions and excessive sedation during sepsis. So this is actually a complete diagrammatic representation of the post-sepsis syndrome. Actually, this single slide would have been sufficient for the entire class, but that's why I have put it at the end. So the cardiovascular, and I will be sharing this PPT and the articles too. So this is actually in a nutshell complete what are all the things happening in the post-sepsis syndrome, follow-up strategies and all. What are the future therapies aimed at reducing the incidence of post-sepsis syndrome? So this is another slide where they have mentioned the sequelae and the proposed pathophysiology. What are the current strategies available and what are the future strategies available? So they have created the sequelae, major sequelae as persistent immune dysfunction, cognitive impairment, PTSD, cardiovascular disease, and the decreased quality of life. So I'm not going to read all of this. Let's discuss what we can do and what we are doing currently for the sepsis survivors in the coming 15 to 20 minutes of what is left of this. Thank you so much for the patient hearing.
Nice slide at the end.
Thank you, Srikanth. Nice presentation. Enlightened everything. Actually, we don't look into this issue of post-sepsis syndrome. Once the patient discharged, they don't contact us and we don't contact them. But what we have seen in our ICUs, majority of the post-sepsis patients again coming with recurrent infections, and they are from the corporates like VPTs and steel plant. These people, because they are free treatment and their number is more, we are seeing more recurrent admissions. But other cash patients we are not seeing because already they spend a lot of money and they don't come, even though they have a post sepsis recurrent infections or other problems.
In solution out on David.
Sir,
if we can make any person, sepsis person who is discharged, if we can make 1 hour for 1 year follow-up free by critical care, that really gives us a full data and everybody can come and they can get treated and we will know exactly what is happening.
1 year free.
From our side, critical care department, like for example, whichever is patient admitted under critical care, we can give 1 year follow-up free.
Follow-up, okay, sir, but what about admission?
Admissions anyway, we cannot make it free. That's it. When you make this free, automatically admissions they'll come, and they come to the cost-effective hospitals.
They'll come to the OPDs of the concerned
primary consultant
OPDs. They are coming.
No, sir. Actually, what Mohan sir is saying that the patients admitted under critical care department means not under primary consultant, because we have two types of patients. One is admitted under us and another is admitted under primary consultant.
Yeah.
So that follow-up is very important. As Mohan sir said, this good idea, and we have implemented in citizen, because as we mentioned to the hospital that in a DNB critical care medicine, 1 week is important. So to follow up of these patients. So we have introduced that concept, and when 4 or 5 or some 10 patients admitted under us, they come for a follow-up. But we used to charge nominal charge around 300 rupees or something, and we used to follow it up, and people used to come. But nowadays, as I am also an OPD doctor, so I'm seeing lot of symptoms, sir. Patients having patients admitting with sepsis in some
What
other
Srikanth
hospital.
told today.
Huh?
Whatever signs and symptoms Srikanth told today.
Yes, sir. So patients come with patients with MI, post MI after having this one having stent placement or thrombolysis, or patient having a CVA with post thrombolysis who has become better. They don't go to the again to the corporate hospitals. My clinic is nearby, so they come in the evenings. So the symptoms are very difficult to treat, sir. And whatever you evaluate, everything will come negative, and they will have some symptoms. I want to ask Srikanth, see, how do I test these patients? What is going on, like a inflammatory response? So some people I do CRP will be normal, and their symptoms are very very vague, and we cannot refer these patients to a psychiatric doctor,
No,
because
don't
they are
send them
having
to
symptoms.
psychiatrist. It's dangerous.
They are having symptoms, mild symptoms, but they're bothering their life. But we are unable to evaluate, and we check into vitamin deficiencies. Everything is coming negative. Srikanth, what should we test it?
Maybe that's more related to the immunosuppressive phase they are talking about, no, sir. In those cases, CRP, I don't think it will come as positive.
Which one?
Immunosuppression, in immunosuppression, if they're going through the prolonged immunosuppression, CRP positive, sir, I don't think. CRP will come as negative only.
CRP is coming negative, and few patients ESR is coming high.
Yes.
So ESR is having high, and that also is an inflammatory response. So we are evaluating, and some few people are really bothered, and they read and Google reading, and they come. So they go for ANA, Cianca, Pianca, and RH. All are coming negative. So, yeah, ICU, it is becoming easy for me, but
See, Srinivas, he has been told. He told that there is at least 9 months of TNF alpha, which is there always positive, not this one. With treatment necrosing, in this presentation, Srikanth presentation, he has mentioned certain things are there, the signs and symptoms up to 52 months, and certain things are there up to at least 6 months, like 150 days. He has told 150 days. 150 days is TNF alpha is present. Till what date TNF alpha present, Srikanth?
Sir, and this at 150 days.
So you see that is almost 5 to 6 months. So 5 to 6 months, if DNF is there and others are absent, then you think about this. That's the way you can see, no?
Yeah. But how do I explain the patient, and how do I prove that you have these symptoms?
Yeah,
So is it
till now
because
you don't
of
know
that
this
only,
lecture. Now
or is
you
it
heard this
because of
lecture,
any
no?
other thing?
Already history of ఉంటుంది కదా శ్రీనివాస్, హిస్టరీ ఆఫ్ సెప్సిస్ ఉంటుంది కదా.
అవును.
హిస్టరీ ఆఫ్ సెప్సిస్ వల్ల ఎన్ని రోజులు ఉంటుంది ప్రాబ్లం తెలుసు కదా. ఇప్పుడు సర్జరీ అయితేనే నొప్పి ఒక 10 రోజులు 15 రోజులు ఉంటుంది గ్యారంటీ, దాని నుంచి పట్టించుకోవద్దని చెప్తాం కదా మనం కూడా.
ఇప్పుడు ఒక యంగ్ పేషెంట్
what they are, even the CDC suggesting also, the current strategies will be physical rehabilitation and psychological support to the patients.
No, this is where you have nutritional and psychological issues.
And psychological issues.
Psychological support, if you don't send the patient to psychiatrist, then who will do counseling?
No psychiatrist. There is a clinical psychologist should be there where they have evaluation process. Actually, this we have a clinical psychologist where they do clinical evaluation separately.
Clinical psychologist having any idea of post sepsis syndrome, all these things?
Yeah, why not? We can tell them, or they don't know if they don't know.
Sir, this problem ఏమవుతుందంటే డేవిడ్ సార్, if you send to a psychiatrist, they write SSRIs, ఏదో ఒకటి రాస్తారు సార్. Okay.
Definitely, patient further deteriorates.
So this one patient has come to me.
Let us not disrespect anybody's knowledge. Let us not disrespect anybody. But I want to tell you one thing: do not send to psychiatrist. Send to clinical psychologist. Clinical psychologist is different from the psychiatrist, because I've seen recently OPD in home hospital where the psychologist fees is only 500 or 600, and clinical psychologist fees is 4,000. Where they do full assessment of the patient and more than 1 hour, clearly they will come to some understanding, because we have very less number of clinical psychologists in the city. Our Hyderabad must be.
Is there in home hospital, sir?
Yeah.
Yeah. Because yesterday one young boy having recurrent attempts of suicides, I told them to go to this home hospital for.
Not to go to the recurrence home is a suicide attempts. It's a psychiatrist only, not a clinical psychologist.
No, let him do psychological evaluation. Then he will refer to psychiatrist for further management.
Yeah, there is a person who separately having
also is important, sir.
Sir, అక్కడ psychologist separate గా ఉన్నారు, clinical psychologist separate గా ఉన్నారు, psychiatrist separate గా ఉన్నారు.
That's why if you send to that hospital, they will take care of everything.
శ్రీకాంత్, ఇది నాకు ఒక పేషెంట్ వచ్చారు. పేషెంట్ ఏమి ఇచ్చారు, పేషెంట్ వాజ్ ట్రీటింగ్ ఫర్ న్యూమోనియా అదర్ హాస్పిటల్లో, అదర్ క్లినిక్ లో. సో నా దగ్గరికి వచ్చాడు, వస్తే చెస్ట్ పెయిన్ తో వస్తున్నాడు. చెస్ట్ పెయిన్ తో, చెస్ట్ డిస్కంఫర్ట్ తో వెళ్ళాడు ఆ క్లినిక్ కి. వాళ్ళు ఏం చేశారు, ఎక్స్రే తీశారు, న్యూమోనియా ఉంది అని యాంటీబయాటిక్స్ రాశారు. 2 days వాడాడు, ఆ చెస్ట్ డిస్కంఫర్ట్ తగ్గట్లేదు. దెన్ హీ కేమ్ టు మీ. దెన్ పల్స్ పట్టుకుంటేనే ఆల్మోస్ట్ 200 కొడుతుంది. ఏందబ్బా ఇదని ఈసీజీ తీశాను, ఎస్విటి ఉంది. వాడికి అసలు అంత ముందు అసలు వాళ్ళు ఎవాల్యుయేట్ చేయలేదు. సరే, నేను మనకు మెడిసిన్స్ తెలుసు కదా, మన క్లినిక్ లో ఇవ్వలేం కదా. సరే, ఐ రెఫర్ టు హాస్పిటల్. వాడు గాంధీకి వెళ్ళాడు, గాంధీ కాదు, ఏజ్కి వెళ్ళాడు. ఏజ్కి వెళ్ళి వాడు ట్రీట్మెంట్ తీసుకున్నాడు. 25 years, సాఫ్ట్వేర్ ఇంజనీర్, 25-30 మధ్యలో ఉంటాడు. He took treatment there, he became better, and he came to me back after 3-4 days he discharged. And then after 1 day he came to me. He says, I didn't just discomfort, but ఈసీజీ చేసినాను, ట్రాప్టీ చేసినాను, నెగిటివ్ వస్తున్నాయి. సరే అని చెప్పేసి మళ్ళీ ఎక్స్రే తీసినాను, నార్మల్ ఉన్నది. ఇట్లా that fellow every 3-4 days comes to me saying that this chest pain. How many times I need to send trophy that patient? సో వాడికి ఏం చెప్పానంటే, అరే యాంజియోగ్రామ్ చేయించుకోరా అని అంటే, వాడు ఎస్విటికి వాడు యాంజియోగ్రామ్ కూడా చేసేసాడు. కొన్నరీ యాంజియోగ్రామ్ ఆల్సో ఇస్ నార్మల్. వాడికి ఈపీఎస్ స్టడీ చేశారు, ట్రీట్మెంట్ ఇచ్చారు, అన్ని అయిపోయినాయి, అన్ని ఇప్పుడు బాగానే ఉన్నది. వాడు బీటా బ్లాకర్ మీద ఉన్నాడు. సో దిస్ వేక్ సిమ్టమ్స్ వెరీ డిఫికల్ట్ టు కంట్రోల్.
చెస్ట్ పెయిన్ రెడ్యూస్డ్?
ఎస్ సార్, రెడ్యూస్డ్, బట్ వాడికి అప్పుడప్పుడు డిస్కంఫర్ట్ అనిపిస్తుంది చెస్ట్.
సార్ ఎగ్జాక్ట్లీ లొకేషన్ కానీ నేచర్ కానీ యూ కెన్
లొకేషన్ వాడికి ఏదంటే చెస్ట్ లో లెఫ్ట్ సైడ్ చెస్ట్ పెయిన్ ఉంటుంది, ఒక్కొక్కసారి రైట్ సైడ్ చెస్ట్ పెయిన్ అంటాడు. వాడికి సిటీ చెస్ట్ కూడా చేయించాను, నార్మల్ ఉంది. సో సంథింగ్ లైక్ హీ డజంట్ హ్యావ్ ఎనీ డిస్క్ పెయిన్ ఆర్ ఎనీథింగ్. సో అన్ని నేను కూడా రెఫర్ చేస్తున్నాను, బుక్కులు రెఫర్ చేస్తున్నాను, ఎవాల్యుయేట్ చేస్తున్నాను జనాల్ని. బట్ these vague symptoms, as you mentioned, it is not only post sepsis. I mean to say that cardiac patients also have some other things which are unexplainable and will be long standing.
So chest discomfort unexplained and not we cannot identify through any diagnostics. There are 3 possibilities here. One, severe GERD, gastroesophageal reflux disease. And sometimes symptoms may be present, sometimes he may have only this symptom. 2, costochondritis, sir. We can actually palpate the chest and all to identify the tender points and all. 3, it can be intercostal neuralgia. Like even pneumonia can trigger an episode of intercostal neuralgia. So acute pain sarga treat cheyapothe obviously it will go into chronic pain. These 3 are the common.
వాడికి ఏంటంటే అడిగి హీజ్ ఆల్రెడీ అండ్ రీసెంట్ గా డిశ్చార్జ్ అయ్యాడు కదా, వాడికి ఆల్రెడీ ఈజ్ హ్యాన్ ప్యాంటప్రోజాల్ ఉన్నాడు. వాడు సో ఒకటి, బట్ ఇఫ్ అది క్యారెక్టర్ ఫీచర్స్ కూడా అట్లా లేవు జిఆర్డి లాగా, బట్ అఫ్ కోర్స్ చెస్ట్ పెయిన్ లాగా ఉండొచ్చు, మెనీ పేషెంట్స్ సీన్ ఇట్. తర్వాత ఇంకోటి ఏంటంటే వాడికి లోకలైజింగ్ పెయిన్ ఏం లేదు, ఈవెన్ వెర్టిబ్రల్ రాడిక్యులోపతి కూడా లేదు. సమ్ న్యూరలాజికల్ సమ్ డ్యామేజ్ ఏమైనా లేకపోతే ఎండ్ ఆర్గన్స్ లో ఎక్కడో ఉండేసి
majority of the chest pains are atypical and psychological problem also. After evaluating everything, I have seen some patients coming to, recently one patient come to gastroenterology department for endoscopy, and he sent for PAC. Then we took ECG. ECG shows MI. He came with only epigastric discomfort, but that patient have acute extensive anterior MI. Then immediately we send the patient to cardiologist. So majority of the patients coming to cardiologist, everything is normal, then they will send them to gastroenterology department. So chest pain is very vague symptom, but at the same time it is very dangerous symptom. If you ignore that, you may lose the patient also sometimes.
One thing
Gastritis.
true that before you say that it may be psychiatrics, you should rule out everything before
Yes,
you say
sir.
it is psychiatric.
After ruling out everything.
అంటే బేసికలీ వై ఐఎమ్ షేరింగ్ మై ఎక్స్పీరియన్సెస్, వి డోంట్ సీ, మోహన్ సార్ చూస్తారు కానీ మిగిలిన వాళ్ళు అందరు చూడకపోవచ్చు, ఎందుకంటే సార్ విల్ అడ్మిట్ ద పేషెంట్స్. సో అంటే దీస్ వేక్ సిమ్టమ్స్ తో వస్తూ ఉంటారు పేషెంట్స్, విచ్ ఆర్ అన్ఎక్స్ప్లెయినబుల్. అంటే ఐ షేర్ దీస్ థింగ్స్ విత్ లాట్ ఆఫ్ ఫిజిషియన్స్, అంటే మన హాస్పిటల్ ఫిజిషియన్స్, వాళ్ళు కూడా ఏం చేయలేము సార్, ఏదో సైకియాట్రిక్ మెడిసిన్ రాయండి, రెస్ట్ ఇవ్వండి అంటారు తప్ప దే ఆర్ ఆల్సో నాట్.
ఇక్కడ అందరూ అడ్మిట్ చేస్తారు సీను, నేను అడ్మిట్ చేస్తాను, రాణి మేడం అడ్మిట్ చేస్తుంది, మౌనంగా శ్రీనివాస్ అడ్మిట్ చేస్తాడు, ఎక్సెప్ట్ డేవిడ్ ఎవరిబడి అడ్మిట్స్.
ఓకే ఓకే, గ్రేట్ గ్రేట్ సార్. దెన్ ఎవ్రీబడి హ్యాస్ ఓపీడీ సార్?
నో, వీ హ్యావ్ ఏ పోస్ట్ ఐసీయూ ఫాలో అప్ ఉంది, కానీ వస్తారు కానీ ఫస్ట్ డే ఫ్రీ, మిగిలిన ఫ్రీ కాదు కదా, అందుకని ఫస్ట్ టైం అందరు వస్తారు, తర్వాత రారు. ఫస్ట్ 15 days కు అందరు వస్తారు, ఎందుకంటే ఫ్రీ కాబట్టి. ఆ తర్వాత నుంచి డబ్బులు కాబట్టి మన దగ్గర ఎవరి దగ్గరికి వెళ్ళాలో ఆలోచించుకుంటారు, అందుకోసమని ప్లానింగ్.
ఇంకోటి మన శ్రీకాంత్ మీరు మెన్షన్ చేశారు కదా ఎన్ని రోజులు యాంటీబయాటిక్స్ తీసుకోవాలనేది, వాడు తీసుకున్నాడు 4 రోజులు అని. సో లాట్ ఆఫ్ పీపుల్ నౌ ఆర్ గోయింగ్ టు హాస్పిటల్ ఇన్ఫర్మేషన్ సిస్టమ్. నౌ అన్లెస్ యూ మెన్షన్ ద డేస్, నంబర్ ఆఫ్ డేస్, it will not be completed. So antibiotic 1 week annara, 10 days, 15 days, 20 days, you have to write it there. If you don't have a prescription of if you have a manual prescription, you have to write up the number of days, because lot of patients, of physician patients who are admitted in the ICU, they send their prescription to me for a guidance later. appudu em avutadante, and some other patients who I have seen and they have followed up some hospital, they send me a prescription, sir ఇది ఎన్ని రోజులు వాడాలి, where it is not written that 1 week or 10 days antibiotics, but రోజు తీసుకుంటూ ఉంటాడు ఇంట్లో. So that mentioning is very important. And one more thing also, I saw one of the patient who is having a blood pressure, I asked him, I written him the medicines and asked him to come after 30 days, into 30 days and రాసేసి 1 month లో రండి, లోపల రండి, ఇది అయిపోతుందని. వాడు ఏం చేశాడు, 1 week డిలే అయింది, వాడు వాడలేదు, వాడకుండా 1 week వాడకుండా వచ్చాడు అండి. వాడు బీపీ హై ఉంది, ఏంద్రా అని అంటే వాడేమో మీరు 30 రోజులు అన్నారు కదా సార్, 30 రోజులు వాడాను, కాకపోతే ఏంటంటే నాకు 1 week డిలే అయింది, అందుకే రాలేదండి. సో దీస్ ఇన్స్ట్రక్షన్స్ హ్యాస్ టు బి గివెన్ వెరీ క్లియర్లీ ఎట్ ద టైమ్ ఆఫ్ డిశ్చార్జ్.
నో, టిల్ ఫర్దర్ రివ్యూ అని రాయాలా, లేకపోతే టిల్ ఫర్దర్ అది, అలాంటప్పుడు మళ్ళీ ఎక్కువ రాకపోతే రాకపోతే ఇందే కదా రాసి అదే తీసుకుంటాను, అది కూడా డేంజరే.
డిశ్చార్జ్ సమ్మరీలో యూజువల్ గా వి రైట్ అదే, యాంటీబయాటిక్స్ అయితే ఫర్ 5 days మోర్ అనో ఏదో, డయాబెటిక్ ఆర్ హైపర్టెన్సివ్ మెడికేషన్, స్టాటిన్స్ అలాంటివన్నీ కంటిన్యూ టిల్ ఫర్దర్ రివ్యూ అని రాస్తారు. సో వెన్ ఎవర్ దే కమ్ టిల్ దట్ డేట్ దే హ్యావ్ టు యూజ్.
yes, agree.
న్యూరో డ్రగ్స్ కూడా అలాంటివన్నీ టిల్ ఫర్దర్ రివ్యూ అని రాస్తారు. 1 month అంటే వాడు 1 month తర్వాత ఆపేస్తాడు, తర్వాత 1 week 2 weeks వస్తాడు శ్రీనివాస్ అన్నట్లు. దిస్ హ్యాపెన్, బయట ఎక్కడో చూయించుకుని 1 month కి వాడమన్నారు, తర్వాత ఆపేసాము అని, తర్వాత విత్ ఇన్ 2-3 weeks మా దగ్గరకు ఒక స్ట్రోక్ పేషెంట్ వచ్చాడు. అన్ని ఆపేశాడు. కార్డియక్ మెడికేషన్, యాంటీప్లేట్లెట్స్ అన్ని ఆపేశాడు. స్ట్రోక్ తో వచ్చాడు.
అవునవును మేడం.
అలాగా. అండ్ మోస్ట్ ఆఫ్ దీస్ పోస్ట్ సెప్సిస్ డిశ్చార్జ్ పీపుల్, వాళ్ళకి నాట్ ఓన్లీ ఫిజికల్ వీక్నెస్, they need psychological support, and they have mental disturbances, lack of sleep, disturbed bowel habits. ఇవన్నీ కూడా ఉంటాయి. దట్స్ వై లైక్ they have loss of confidence. And follow-up clinics వచ్చినప్పుడు they tell like they are unable to take food, and they have more number of motions in a day compared to previously, and diarrheas and all these. They have IBS kind of picture. So because they use lot of medication during admission, that's a common thing. So even like a gastroenterologist, what is he called, Nageshwar Reddy sir, he said for up to 3 to 6 months ఒకసారి they have to have probiotics with something Redotril or something BD dose, and it will settle. So చాలా సార్లు మా దగ్గర రీహాబ్ లో కూడా this is the common complaint post ICU discharge patients ki. And physiotherapy and increasing the muscle power, increasing the confidence, boosting their confidence, and vitamin and mineral supplements, micronutrients, high protein diet, and as we all said, clinical psychology consultation. And every day, day by day, like if somebody like medical or not psychiatrist, psychologist side, somebody, if they talk and boost them, they feel better. And for sleep disturbance, sometimes they need some anxiolytics or sleeping tablets. If they sleep well in the night, they look fresh in the daytime. So if they're not sleeping every day, they look more irritable and more anxious in the daytime. They don't do physio properly. So all these we notice. So there are a lot of elements like which at home they may not receive properly. They say they're not doing well, they're not sleeping, not eating, they're getting irritable. They have all these aches and pains because they think he's discharged from ICU, so you have to be in bed for few days. But that causes more aches and pains. You have to do more gradual increase in physio. Then only you gain muscle power. So the aches and pains will go down. So this is all what we noticed. And high protein diet. And also like don't keep them all alone to recover in their room. Once they are fully recovered, and call their close associates or close friends, or have a little gathers to cheer him up. All these things also kind of psychological support. So all these also will help reducing their disturbed minds and post-sepsis syndrome. This is all what I noticed. Thank you.
Agree, madam. Actually, these all things we don't see much, but I think our team has a good experience.
I have shared one life after sepsis fact sheet yesterday in the groups yesterday night.
అది చదివాను శ్రీకాంత్, బాగుంది.
Yeah, it's published by CDC sir, US లో.
అది CDC మీద వచ్చింది, పేషెంట్స్ కోసం ఉంది. ఎనీవే, ఇప్పుడు రాణి మేడం అంతా రీహాబిలిటేషన్ సెంటర్ గురించి చెప్పింది కదా, ఎక్స్పీరియన్స్ ఆఫ్ దట్.
Okay, Srikanth, thank you very much for a nice presentation. Thank you all the audience for active participation. Thank you. We'll close the session.
Thank you, Srikanth.
Thank you, Jekina, for your OPD cases.
Thank you, sir.